Okay, very good evening, dear students. So, as in these integrated sessions, today I will discuss the neurotic disorders in psychiatry. In all recent exams, you must have seen, and always I discuss in classes that there is a the vital role these minor subjects they play. Whether the next will be there, when it will be there, that's it still the question mark. But whenever it will be there, you have to understand that the topics will remain same. So if you have a good concept, then you will not have whether there any change in the exam pattern. We'll discuss today in detail the neurotic disorders. When we talk about the neurotic disorders, in neurotic disorder, the first, if we'll discuss that in psychiatry there are two important broad category: neurotic disorder and the neurosis and psychosis. So first we'll understand one concept, and then we'll talk about neurotic disorders in detail. When we talk about neurosis and psychosis, basically we have delusion and hallucination. We have delusions and hallucination. Delusions and hallucinations, they are always part of psychosis. They are absent in neurosis. Second, insight. Basically, what is insight? Insight is awareness of illness. You come to me, sir, I feel low, I don't feel motivated, I am not able to focus on study, I am not able to, go to gym, I am not able to sleep properly, I am, feeling fatigue, I feel weak. Please help me out. So you have symptoms and you are aware about your symptom. This is what insight is present. So basically, what is insight? Insight is awareness of illness. Insight is present in neurotic disorder. Insight is absent in psychotic psychosis. Judgment and contact with reality. And contact with reality is basically preserved neurotic disorder, and it is impaired in psychotic disorder. Okay, judgment, that judging the immediate situation. The contact with reality is preserved in neurotic disorder, it is impaired in psychosis. So neurosis, basically delusions and hallucinations are absent, insight is present, and the judgment and contact with reality is preserved in neurosis and it is impaired in psychotic disorder. Now, so this is the basic difference between neurosis and psychosis. When we talk about neurotic disorder, first we'll talk about anxiety disorder. Anxiety. In anxiety disorders, first we'll talk about anxiety. The first MCQ, they ask about anxiety. In anxiety, basically, what are the symptoms of anxiety? Anxiety is a having two symptom, somatic symptom and psychic. Somatic symptoms, the examples of somatic symptoms of anxiety are, somatic means body related symptom, sharir se related, the dryness of mouth, dryness of mouth, okay, palpitation or tachycardia, sweating, respiratory difficulty, Okay, respiratory difficulty or choking sensation. Patient will say कि sir सांस में दिक्कत आ रही है, so respiratory difficulty or choking sensation. Okay, patient will have bloating sensation. Okay, or butterfly kind of thing in a abdomen. Acidity, always there is a gas formation or acidity in the it's a part of anxiety disorder. Okay, bloating sensation. Patient sometime the very cold skin after having a symptom of anxiety, cold skin. Okay, so these are the somatic symptom. Even sometime feeling of diarrhea. Whenever you're having some anxiety symptom, you rush to the washroom. This is a diarrhea like sensation. That's why the irritable bowel syndrome, it's a basically anxiety disorder. When person having a sometime feeling of diarrhea, sometime feeling of constipation. So these are the somatic symptoms. The psychic symptoms of anxiety are apprehension about future, apprehension. Okay, feeling of impending doom. Okay, today is my last day, I am going to die, that kind of feeling. So we have a somatic symptom and we have a psychic symptom in anxiety. Okay, these sometimes they ask all of the following are anxiety symptom except. First, when we talk about the anxiety disorder, the first we'll talk about the panic disorder. Panic disorder, again and again they are asking about panic disorder. In panic disorder, patient present with the panic attack. Panic attack. What is panic attack? Very commonly we use this word, I have panic attack. Okay, so what is panic attack? Three important points about the panic attack. Number one, it's a sudden or acute onset. Panic attack having a acute or sudden onset. The peak of the symptom between 10 to 15 minutes. 10 to 15. Patient suddenly will say, sir, I started having palpitation or tachycardia, respiratory difficulty, dryness of mouth, and the peak of this symptom will be within 10 to 15 minutes, and patient will feel today I'm going to die, today I'm like मैं नहीं बचूंगा, today is my last day. And then so the peak is between 10 to 15 minutes. Patient will have somatic and psychic complaints, as I mentioned, psychic symptoms. Okay, that what are the somatic and psychic symptoms. So patient will have crescendo and decrescendo feature in panic attack. Anxiety symptom will increase, will go to the peak, reaches in 10 to 15 minutes, and then they start subsiding, so that the episode lasts in like 15, 20, 30 minutes, and thereafter patient the energy got drained. Patient will feel like today energy less person. So this is a one panic attack. Whenever we have panic attack, then we have to rule out the organic causes of panic attack. Sometime because many times these patients they feel that I will have heart attack, or they always go to the either cardiologist mainly, or they go to the gastroenterologist because they're having a acidity or gas symptom. So what are the organic causes of panic attack that you should know? The organic causes of panic attack. Number one, hyperthyroidism. Hyperthyroidism can mimic like a panic attack. Okay, hyperthyroidism. Number two, arrhythmia. So arrhythmia, hyperthyroidism. Okay, carcinoid syndrome, hypoglycemia, hypoglycemia, epilepsy, mitral valve prolapse, mitral valve prolapse, chromocytoma, okay, asthma, COPD. These are the basic important organic causes of panic attack, okay, that you have to remember. They usually ask all of the following are organic causes of panic attack, or sometimes they basically, you know, rather than asking directly organic cause, they will say the patient presented in emergency with the panic attack, what all investigations you would like to accept. So what all investigations you would like to do or to rule out the hyperthyroidism, what you will do, thyroid profile. To rule out arrhythmia, what you will do, ECG, hypoglycemia, blood sugar level, epilepsy, will do the EEG. Okay, pheochromocytoma, you can say 24 hours urinary catecholamine level. So these are the important investigations like ECG, thyroid profile, EEG, blood sugar level. All these you can do. Usually when they ask this MCQ, they usually give the one option, and that is what, complete hemogram, CBC, complete hemogram. Basically nothing to do with the panic attack. So these are the organic causes you rule out. Once you ruled out the organic cause, it means it's a functional, it's a psychiatric. And if we have 4 panic attacks in 1 month, then it's a panic disorder. Then it's a panic disorder. So 4 panic attacks in 1 month, we call it a panic disorder. If they ask you that what are the neurotransmitters, okay, neurotransmitter involved in anxiety disorder or panic disorder, they are the serotonin, they are norepinephrine, GABA, cholecystokinin, that you have to do. Okay, so there is a decreased level of serotonin, the norepinephrine, we have a GABA involvement, we have a cholecystokinin involvement, that also they can ask. So these are the neurotransmitters involved in a anxiety disorder, or you can say panic disorder. If they ask you the treatment of panic disorder, your answer will be any anxiety disorder including the panic disorder. Usually the treatment is mainly the we have behavior therapy. So 2-3 MCQ they can ask you here. One is, if they ask you treatment of choice, then your answer will be what, CBT. Your answer will be cognitive behavior therapy. If they ask you the treatment of choice, if they ask you that what is the best modality of treatment, then your answer should be CBT plus SSRI plus benzodiazepine. Okay, so CBT plus SSRI plus benzodiazepine is a treatment of choice. Sorry, the best modality. The treatment of choice is what? CBT, cognitive behavior therapy. One drug they are asking here, buspirone we have. Okay, buspirone. So we have a bupropion and we have a buspirone. Bupropion is a basically anti-anxiety drug, 5-HT1A partial agonist. Okay, it's a anti anxiety that they are asking. 5-HT1 a partial agonist, and bupropion basically, please remember, it's a antidepressant, norepinephrine, dopamine reuptake inhibitor. Okay, reuptake. So that don't get confused between bupropion and buspirone. Okay, so if they ask you the treatment of choice, cognitive behavior therapy. What is the best modality of treatment? Combination of medication plus CBT. And medications are SSRI, selective serotonin reuptake inhibitors, and benzodiazepines, and the CBT, best modality of treatment. Sometimes they ask the buspirone, it's an anti-anxiety drug. The mechanism is 5-HT1 a partial agonist. Clear? So this is about the treatment. So in panic disorder, what they ask, they will ask about the panic attack. What is panic attack? I told you. Then there is the organic causes of panic attack. Either they ask directly organic cause, or they will ask which investigations you would like to do, and then they will ask the 4 panic attacks. If we ruled out the organic causes, if we have a 4 panic attacks in 1 month, then we call it a panic disorder. What are the neurotransmitters involved in a panic attack? Serotonin, cholecystokinin, norepinephrine, GABA. Treatment I mentioned. Okay, this is about the panic disorder. Another anxiety disorder they can ask you, and that is GAD, generalized anxiety disorder. Sometimes they are asking generalized anxiety. Generalized anxiety disorder, as the name suggests, generalized, free floating anxiety. This is one word we are using in generalized, free floating. Okay, free float. Why we call this session is a like integrated, like panic disorder we discussed. In panic disorder, believe me, patient never go directly to the psychiatrist. They always go to the cardiologist because they think that they will have a heart attack or something. They do multiple ECG, they do the the whole angiography, the Holter, everything. So many investigations in cardio department, or they will go to the gastroenterologist because they feel that they have acidity, they have some gastric issue, and they go to the gastroenterologist. And later on, after doing the multiple investigations, wasting a lot of money and time, then they ultimately reach to the psychiatrist. That's why panic disorder, people don't understand that they feel they have a sudden anxiety, and they have a heaviness over the left chest, and this directly connect it with the cardiac issue. In generalized anxiety disorder, anxiety is everywhere. We call it a like free floating anxiety. Everything patient having anxiety. So in anxiety, generalized anxiety disorder, we have two important criteria. We have a major criteria, have a minor criteria. The major criteria, the two important major criteria are unnecessary worry. Patient having a unnecessary worry. For minor thing, he or she is having a overthinking, worries. Patient knows that it is unnecessary worry, but patient is not able to control that worry. Why patient is not able to control? Because it's a like patient knows why, because it's a neurotic disorder, insight is there, but patient is not able to control that. Not because it's a illness, so patient is not able to control that worry. Not able to that. And that's why patient will have symptoms like restlessness, have irritability. Patient will have sleep disturbance, have muscle tension. Okay, patient will have easy fatigability, and patient will have decrease sun. So there are two major criteria, and there are 6 minor criteria like irritability, restlessness, sleep disturbance, muscle tension. Because patient, because of anxiety, always we have, that I have a back pain or the neck pain, it is because of anxiety. There's a contraction of muscles, and because of that person having a muscle pain, fatigability and decrease concentration. So there are two major criteria, six minor criteria for making a diagnosis of generalized anxiety disorder. We require at least two major and three minor criteria at least for 6 months. We can make a diagnosis of GAD, generalized anxiety disorder. So two major criteria, and among these six there are three minor criteria. A patient fulfills that he or she is suffering from generalized anxiety disorder. Treatment, yes, usually they ask about the diagnosis in the generalized anxiety disorder because treatment is the same. This, we give the antidepressant, we give the various therapies. Okay, one word we are using anxiety, and one word we are using phobia. What is the difference between anxiety and phobia? Basically, you know, anxiety is a internal vague threat. Okay, internal vague threat. Phobia is a external definite threat. Okay, definite threat. Basically, in anxiety and phobia symptoms are same, but in anxiety we don't have object. In phobia we have particular object. That's why we'll say that it's an external definite threat, and the anxiety is an internal vague threat. Vague threat, we don't have any object. It's a person just having a symptoms. Okay, so this is a difference between anxiety and the anxiety there is no object. In phobia there is an object. Okay, otherwise usually we, the symptoms are same. Sometimes they ask the name of these phobias, so we should know that what are the specific phobias we have. In specific phobias, they usually ask in DSM-5. We have a, the different type of phobia they have, described DSM-5, like the animal type, then neutral environmental type, the blood injury type. Okay, but basically usually they ask the sometime, this, what are the situational phobias, and that they ask many times the name. So we have a fear of closed space. Fear of closed space. Then we have fear of closed space is claustrophobia. Claustrophobia. Okay. Fear of height. Acrophobia. Okay. Fear of pain. Algophobia. Gophobia. Okay. Fear of death. Thanatophobia. Thanatophobia. Fear of cat. Okay. Neurophobia. Fear of dogs. We have cynophobia, that they ask sometime. Fear of strangers. Okay. Xenophobia. Xenophobia. Fear of fire. Pyrophobia. Okay, fear of germs, mesophobia. Fear of darkness, nyctophobia, that they asked recently. Nycto, NYCTO. So Zums, Miso, Pyro, Stranger, Xeno, Dog, Sino, Cat, Alorophobia, Death, Thanatophobia, Pain, Algophobia, Height is a acrophobia, and the closed space is a claustrophobia. Claustrophobia. Okay, so these are the various specific phobias. We have the situational specific. Okay, one we have agoraphobia. One we have agoraphobia. Agoraphobia, the most common type of phobia that you have to remember, that they ask the most common type. What is agoraphobia? It's a patient having a phobia of two specific places. Two specific, like closed space, open space, height, the closed space, two specific places, and patient having a avoidance behavior. Avoidance, avoidance behavior. Avoidance behavior. So patient having a two specific place and avoidance behavior. Most common type of phobia, agoraphobia. Now we, as I mentioned, that we give the medication to control this anxiety or phobic symptom, but the ultimate solution is a behavior therapy in anxiety disorder. So what they can ask in behavior therapy, what MCQ you should remember. The behavior therapies we are using in anxiety disorder, the first is systemic desensitization. The systemic desensitization, as the name suggests, systemic desensitization, the gradually we desensitize the patient from the phobic object. It's the most commonly used therapy, the most commonly used behavior therapy, most commonly. We have 4 steps in systemic desensitization. The first step, the relaxation. We teach the patient relaxation exercise. Okay, we teach the patient relaxation exercise, and the specific relaxation exercise we use JPM, Jacobson progressive muscle relaxation. Patient in a relaxed position. Now we use the first step, relaxation. The second step is we use imagination. Suppose a particular patient having a phobia towards lizard, Chiptli phobia. So in girls it's very common. So suppose one girl having a phobia towards lizard. First we teach her relaxation exercise. She is relaxed. She does that JPMR. Thereafter we start the session with imagination. But when person, suppose even she will imagine about the lizard, it will create a anxiety or will give her panic attack. Okay, so imagination. Gradually after 4 to 5 sessions, 6 sessions, she now doesn't have any difficulty in imagination. She's comfortable, she's okay with it. Then the third step is a artificial object. We do the session with the artificial lizard, artificial, and then we have a real object. So we have relaxation exercise, we have imagination, we have artificial object, and then we have, when the person is comfortable with the artificial lizard, then we do the session with the live lizard. So this is a like, we started with the relaxation exercise, then the imagination, then the artificial object, then the real object. So this is what, as the name suggests, systemic desensitization. We gradually, step by step, we desensitize the person or the patient from the phobic object. We call it as systemic desensitization. Most commonly used behavior therapy that they ask. Okay, so you have to remember two important point. Most commonly used. Second, there are 4 steps. Okay, and we through this step we gradually desensitize the patient from the phobic object. The second type of behavior therapy, we use graded exposure. Graded exposure. Graded exposure, basically it also we use the steps, but the basic difference between graded exposure and systemic desensitization is what? The relaxation exercise, the first step which we have used in a systemic desensitization, is not a part of graded exposure. Okay, so graded exposure, we start with the imagination, then the artificial object, then the real object. So we have only 3 steps. We have 3 steps in the graded exposure. We have 4 steps in a systemic desensitization. So you have to remember the basic difference between systemic desensitization and graded exposure is what? Relaxation exercise is not a part of graded exposure. Okay, and the third type of behavior therapy we have flooding. Flooding. What is flooding? Flooding is a direct exposure to the live object. Direct exposure to live object. Suppose a patient having a phobia towards the lizard. I told you the girl having a, that person, one particular girl having a phobia towards the lizard. We take her and close in the room with the live lizards. This is a flooding, that without using the, these steps, we directly expose the patient to the live object or the phobic object which is having a fear. This is a flooding, direct exposure. So we usually don't use the flooding. Why? Because it can create the severe anxiety in the patient. It can be the having a dangerous consequences. So unlike you don't like the patient, you should not use flooding. And you know that we always, as a doctor, we should love our patient. We have to have respect towards the patient. So this is a flooding, direct exposure to the live object. These are the important behavior therapies we have: flooding, systemic desensitization, and the graded exposure. Systemic desensitization is the most commonly used therapy, behavior therapy. 4 steps. Graded exposure, 3 steps. Which step we don't have in graded exposure? Relaxation exercise, and the third is flooding. So this is about the basic symptoms of anxiety, the panic disorder, generalized anxiety disorder, and the various phobias and behavior therapies. Okay, yeah. Now the one important disorder they basically ask, and that is what? The we have a obsessive compulsive disorder. Okay, obsessive compulsive disorder. So that we will discuss one by one, that what they can ask in obsessive compulsive. Okay, basically obsessive compulsive disorder, previously we were saying obsessive compulsive, now we say obsessive compulsive and related. Obsessive compulsive and related. In DSM-5, that you have to be very careful about the DSM-5 and ICD-11. They are repetitively asking about these recent changes. These are the hot important areas. So before we were having a obsessive compulsive disorder, now in DSM-5 and ICD-11 we have the ICD have obsessive compulsive and related. So some other disorder also be included there. So what obsessive compulsive and related disorder we have? Number 1, OCD, obsessive compulsive disorder. Number 2, we have hoarding disorder. Okay, hoarding disorder. Number 3, the body dysmorphic disorder. order. Okay, the fourth we have olfactory reference syndrome. Olfactory reference syndrome. And the fifth we have body focused repetitive behavior. The body focused repetitive, the body focused basically in body focused repetitive behavior we have trichotillomania, trichotillomania, and we have excoriation. That five disorder we have under obsessive compulsive and related disorder. One is OCD, second is hoarding disorder, the third is body dysmorphic disorder, the fourth is olfactory reference syndrome, the fifth is body focused repetitive behavior. Under body focused repetitive behavior we have trichotillomania and we have excoriation disorder. So one by one briefly we'll discuss about it. The first is OCD, obsessive compulsive. In OCD we have obsession. What is obsession? OCD, again and again repetitively they are asking this area, so you have to be very careful. Obsession, person having a repetitive thoughts. Suppose you wash your hand once, after washing your hand you start having thoughts, my hands are dirty, my hands are dirty, मेरे हाथ गंदे हैं. These are thoughts which are repetitive. Because they are repetitive, they are anxiety provoking. They provoke the anxiety. Why? Because person thinks that these thoughts were not occurring to me before, they were not happening to me before. Why these absurd nonsense faltu ke thought, unwanted thought started coming to me? They are the the anxiety provoking. And because patient not having these thoughts before, now suddenly they start, that's why we say they are ego dystonic. That's a very important MCQ. They again and again are. So one is we have ego dystonic and one we have ego syntonic. Basically what is ego dystonic? Ego dystonic is not familiar to one's personality, not familiar to one's personality. Patient will say, sir, before they were not occurring to me, I don't know why these absurd unwanted thought started coming to me. So they are not familiar to one's personality, they are ego dystonic. So please remember, very very important MCQ this is, that obsession is ego dystonic. And we basically have what we have, the delusion, which are ego syntonic. Okay, in delusion patient is not distressed. Suppose patient says, sir, he wants to kill me, the delusion of persecution. Patient is not distressed because of thought, patient is distressed because he thinks that somebody wants to kill him. So delusion are ego syntonic, obsessions are ego dystonic. Delusion in mental state examination, another just important MCQ I will tell you. In mental status examination, delusion we describe under thought content. We describe under thought content. Okay, thought content in one of the heading of mental status examination. And the obsession we describe under thought possession. Okay, we describe under thought possession, or you can say possession of thought possession. So obsession we describe under thought possession, delusion we describe under thought content. Clear? Yeah. So obsessions are anxiety provoking, they are repetitive thoughts. Patient, because they are ego dystonic, patient try to resist these thought. When patient is not able to resist, then patient does the compulsion. Does. Okay. And in compulsion, basically patient having a irresistible repetitive behavior. Irresistible repetitive. So we have obsession and we have compulsion. Now they are asking, the person does the repetitive, that irresistible behavior. Now they are asking the basically 2-3 MCQ they can ask. Number one, that what's basically in etiology. They can ask that what's the biochemical theory of OCD, the serotonin dysregulation. Where this serotonin dysregulation occur? The serotonin dysregulation basically occur in a uh, the which loop occur? Cortico striato thalamo cortical. Okay, so basically the cortico striato thalamo cortical loop or tract is involved in OCD, that you have to remember. Okay, so we have orbitofrontal cortex, then we have the caudate, yes, then we have thalamus, and then the orbitofrontal. Okay, so these are the tract: corticostriatothalamo-cortical tract or orbitofrontal cortex, the caudate, the thalamus, and then the orbitofrontal cortex, that they can ask. Apart from that, in the childhood OCD, we have involvement of pandas. Pandas is basically we have the autoimmune pediatric auto. Okay, the neuropsychiatric disorder associated with beta hemolytic pepto infection. So pediatric autoimmune neuropsychiatric disorder associated with beta hemolytic streptococci. Basically it's a basal ganglia autoimmune reaction to the basal ganglia. Okay, so this is the basically the autoimmune response to basal ganglia that sometime they ask. Okay, and because of that patient will have OCD, and also there is a development of tics, obsessive compulsive disorder, and development of tics. Okay, this is they are asking. If they ask you the prevalence of OCD, obsessive compulsive disorder, then your answer will be roughly 2 to 3%. Not a quite high patient, but still we don't have a good awareness and acceptance of OCD. That's a different thing. Okay, if they ask you the types of obsession, types of obsessions are types of obsession. We have contamination. Okay, the contamination, religious symmetry, contamination, religious symmetry. Okay, aggressive obsession. Contamination, the dirt related, my hands are dirty, my body is dirty, my house is dirty, the most common type of. religious patients see the the some you know the naked picture of god and goddesses, sometimes the imagery kind of thing in front of his eyes, and sometimes suppose passing to the temple or the passing to his or her religious place, they having a some bad thoughts about the god, or the while doing the worship they have a bad thoughts about the god, and he starts giving the stress to the patient, because patient think that how I can think bad about my god. Religious obsession. Symmetry, order. Patient wants the things in a very particular manner. So, my slipper should be like this, my bed sheet, my books, everything in a particular arrangements. Okay. Symmetry. Obsessive person having a that obsessive fear, person having obsessive impulse. Obsessive impulse. Obsessive fear and obsessive impulse. Obsessive fear, that something I can do the socially socially embarrassing act, or the obsessive impulse person is having do something assaultive nature. Obsessive, these are the obsessions. So most common type of obsession is contamination. The and that if they ask you the types of compulsion, types of compulsion, then your answer will be washers, checkers. Understand? Check. Before we were saying that most common type of obsession is a contamination, and most common type of compulsion is washers. But now the most common type of compulsion is not washer, it's checker, that you have to remember. Okay. So most common type of obsession is a contamination. Most common type of compulsion is checkers. Checkers. Okay. If they ask you the treatment of OCD, the treatment of choice in OCD is behavior therapy. Which behavior therapy? The exposure and response. Exposure and response. Person having a suppose having a obsession of contamination. We want to do the ERP. We expose to the patient. Suppose we ask the patient to wash hand once. Once person washes his hand, this is exposure. Now we ask the patient to sit in a session. We don't allow him to wash hand again and again. So we're preventing what? Response. Patient anxiety will increase gradually. We'll check the BP and the pulse rate in every 15 minutes. After 40-45 minutes, patient anxiety will start subside. Basically, the what is through the exposure and response prevention, we basically making patient realize that if you don't indulge into the compulsion, even through our physiological mechanism in our body, anxiety will automatically subside. So this is a exposure and response. So exposure is basically patient exposed to the situation, and then we prevent the response. So this is the exposure and therapy. Exposure and response. And if they ask in exposure and response prevention, which is more important, exposure or response prevention, then your answer will be response prevent more important than action. You expose to the situation, if you don't prevent the response, then patient will keep washing his hand. So response prevention is more important than action. Okay. If they ask you the drug of choice, then your answer will be fluvoxamine. So before we were saying the fluoxetine, but the fluvoxamine is better drug than fluoxetine. Okay. If they ask you the best modality of treatment, the best modality of treatment will be ERP plus SSRI, say the CBT plus. Okay. So the treatment of choice, exposure, and drug of choice, fluoxamine. Best modality of treatment, either ERP or CBT plus SSR. Okay, if they ask you, please remember the OCD is a psychiatric disorder where we use the treatment like surgery. Okay, we do the cingulotomy, the caps. Please remember, OCD is a psychiatric disorder where we use surgical approach, cingulotomy and capsulotomy. Okay, deep brain stimulation is one type of somatic therapy we use in a treatment resistant OCD. The FDA approved treatment in treatment resistant OCD patient. Deep brain deep and that they can ask about the secondary depression, very common in OCD, that they ask that secondary depression seen in which psychiatric disorder. OCD patient having a OCD, and because of this stress patient develop the depression, so it's like secondary to OCD, so that's why we call it a secondary depression. The second I mentioned that we have a hoarding disorder. Second obsessive and compulsive related disorder is a hoarding disorder. Hoarding disorder, patient basically having a collection of patient like acquiring, okay, and inability discard things, discard which are not useful. The person having a acquire, he or she acquire the things, or he or she is unable to discard the things which are having a no value or minimum value. This is a hoarding disorder. Okay, basically that MCQ they are asking that ERP is not useful in hoarding disorder, that's why it has a worse prognosis. Okay, worse prognosis. That MCQ they are asking that which obsessive compulsive and related disorder having a worse prognosis, answer will be ER. So the answer will be hoarding disorder. The third type of obsessive and compulsive related disorder, the body dysmorphic. Okay, in body dysmorphic disorder, person having a preoccupation regarding some imagined defect. The patient having preoccupation regarding this preoccupation regarding some kind of person either having a some anomaly in physical appearance, or there is no issue, but patient having a just some kind of imagined defect, and that's why the person having a preoccupation regarding this imagined defect, and person because of that person having a some kind of mental act. Patient having a mental acts like a comparing himself with others. Okay, comparing himself with the others, or person having a this mirror checking, he check himself again and again, himself or herself in the mirror. Okay, this is usually body dysmorphic disorder are related to the nose, the skin, okay, hair, this kind of imagined defect person having about his or her body. Okay, person having this body dysmorphic disorder with the good insight, person having with the poor insight, person having a body dysmorphic disorder with the absent insight. So good insight, poor insight, and the absent insight. Okay, then When absent inside, it appear like a delusional, belief, okay, that we have to see, and accordingly we have to treat the patient. The fourth obsessive compulsive and related disorder, we have olfactory reference syndrome. Olfactory reference syndrome, already I mentioned. Basically this disorder we have only in ICD, we don't have in DSM-5. Okay, so in DSM-5 other obsessive compulsive and related disorder we have, but not the olfactory reference syndrome. Okay, olfactory reference syndrome, basically person having preoccupation that he or she is emitting a foul odor. Okay, or the preoccupation that he or she is having emitting the foul odor from his body or breath. Okay, and person having a repeated checking. Okay, or he avoid the situation. Okay, avoid the situation. This is a olfactory reference syndrome in ICD-11. And the last we having the fifth one, we having the body focused repetitive behavior, that we have trichotillomania, and 𝐬𝐿. Trichotillomania is repetitive hair pulling, so repetitive pulling of hair. Okay, trichotillomania. And excoriation disorder is basically repetitive picking of skin. Repetitive picking of skin. So these are the obsessive compulsive and related disorder. We have OCD, we discussed, hoarding disorder, then the body dysmorphic disorder, and we have olfactory reference syndrome, and we have body focused repetitive behavior, trichotillomania and disorder. So in today's session we discuss the anxiety disorder, then we discuss that anxiety symptoms, panic disorder, generalized anxiety disorder, various phobias, the treatment of this phobia, behavior therapies. Okay, and then obsessive compulsive disorder, and these are related. Okay, yeah, there was a person who has given the 𝐀𝐛𝐨𝐮𝐭. Okay, the 𝐀𝐛𝐨𝐮𝐭, he has given the okay, he has given the general adaptation syndrome. Okay, general adaptation syndrome. 𝐀𝐛𝐨𝐮𝐭, in general adaptation syndrome, he basically described the stages. So what are the stages of general adaptation syndrome? The first is alarm stage. Okay, alarm stage. Second stage is stage of resistance. Third stage is a stage of exhaustion. Alarm stage, when the person having the initial any kind of situation we have, that stressful situation, there is a activation of sympathetic nervous system. Because of activation, there is a sympathetic nervous system get activated, there is a release of SCTS. Okay, and ultimately release of what? Cortisol and adrenaline. Okay, adrenaline. Okay, and person having a goes in a alarm state. Okay, a person, the body prepare to the to respond to the that situation, okay, fearful situation. Then stage of resistance is still there's a over activity of HPA axis, okay, still body the resist to that situation, okay. And then the stage of exhaustion, okay, basically the prolongation of stress causes this, gives this stage. So these are the three stages: alarm stage, the stage of resistance, and the stage of exhaustion given by the 𝐀𝐛𝐨𝐮. We call it a general adaptation syndrome that the MCQ they are asking, okay. So this is about that. Today we covered the anxiety disorder and obsessive compulsive and related disorder. Next session I will come with the different topic. But guys, please, now we, because of this next, we are on through this our channel, we are trying to give you that exposure how to, you know, integrate the one subject with the another subject. Sometime 2 3 faculties we are coming together, and sometime, you know, one session discussed by the one faculty. Just go through this session. I hope you will enjoy it, okay. And soon I will come with another session. Till that, bye bye, take care, be healthy, take care about the health and about the as a psychiatrist I request you, mental health is very important. Exams and all these things, the biggest exam is a life, you know. Things will come and things will go, but please don't break. Go ahead, go slowly, you know, with the positive attitude, work hard. The continuous, you know, the persistence, the continuity, the hard work, clear goal, clear vision in life will take you there where you want to reach, okay. In between there will be problem. Please take your friends help, take, be close to your family, to your friends. Still you are not able to cope up, take the professional help nearby your with professional or in your medical college. Understand the psychiatric problem like a medical illness. We have a clear cut, you know, neurobiology established and everything. They are the brain disorder, okay. So don't hesitate. If you have some problem, you know, take the professional help. But you know, life is more important. If nothing is more important than the beautiful, so keep that in your mind, okay. Good night, god bless you, see you soon with the another. Bye bye.